Roman, you could start.
Okay. Buenos días, buenas tardes, buenas noches a las y los colegas y a toda la audiencia que va a disfrutar de este importantísimo webinar sobre enfermedades crónicas no transmisibles. Es un placer para mí introducir brevemente el webinar en nombre del Movimiento para la Salud de los Pueblos. Para nuestro movimiento, la carga de enfermedad y de muerte generada por las enfermedades crónicas no transmisibles es y ha sido tan grande como la desgracia generada por la pandemia del COVID-19. Nosotros saludamos los avances obtenidos hasta ahora en la lucha contra los determinantes de esta carga enorme de enfermedad y muerte en el mundo. Pero asimismo, tenemos serias preocupaciones sobre las dificultades para que este avance sea mucho más efectivo y sobre todo en beneficio de los pueblos del mundo en peores condiciones socioeconómicas, especialmente de los países de ingresos medios y bajos, quienes soportan de modo más grave la carga de esta tragedia que hoy nos azota en el mundo. Creemos que el plan de acción global que ha establecido la Organización Mundial de la Salud, si bien tiene importantes decisiones que ayudarán a enfrentar los desafíos que tenemos, aún padece de debilidades que nos preocupan. Por ejemplo, nos preocupa que las decisiones estén limitadas por intereses globales de, por ejemplo, grandes corporaciones que aún inciden en el contenido de estas decisiones. Nos preocupa que el énfasis central se oriente hacia el comportamiento de los individuos y a los factores de riesgos, pero que no haya un nexo fuerte y claro con las determinaciones sociales detrás de la explicación de las enfermedades crónicas no transmisibles. Nos preocupa que determinantes económicos, sociales, comerciales, culturales y políticos no sean suficientemente confrontados por las decisiones que se están promoviendo a escala global. En todo caso, para el Movimiento de Salud de los Pueblos, fuertemente comprometido en la lucha por la salud para todos y todas, es muy importante que en esta discusión de hoy podamos alimentar reflexiones a distintos niveles de país, de regiones y globales que ayuden a enfrentar los desafíos no resueltos. Bienvenidas, colegas y compañeros y compañeras, a este seminario, a este webinar, que ayudará mucho a esclarecer el camino que deberemos seguir para lograr victorias cortas, de corto plazo, de mediano y largo plazo, importantes para garantizar el derecho a la salud y para lograr un mundo en el que el bienestar y el buen vivir de los pueblos sea una realidad. Vamos a introducir ahora a nuestro primer presentador en este webinar, Billy Wangasa Katia Wamba, es uno de los primeros. Since 2020, he is also the coordinator of the Popular Movement for Health in the Democratic Republic of Congo. Previously, he was the Commissioner of the Interior in the Parliament from 2011 to 2015. The place of mental health in the conflict is a textbook case with a lot of post-traumatic stress, poor nutrition, and the conflict that prevents people from having access to health care is also responsible for many non-communicable diseases. With these experiences, Billy will make the presentation. Thank you very much, Billy, for attending our invitation. Please go ahead.
Merci beaucoup pour la parole. Je vais déjà commencer ma présentation. J'ai pris un contexte général parce qu'aujourd'hui, en Afrique centrale, il y a un problème de guerre, des conflits armés, des violences sexuelles, et ceux qui sont accompagnés par la pauvreté et qui créent des facteurs inexplicables de troubles de santé mentale en Afrique centrale. Je suis allé un peu pour réfléchir sur la situation socio-économique et sécuritaire de la RDC, parce que je vais beaucoup me focaliser sur le contexte de la RDC, mais c'est un contexte qui généralise un peu plusieurs pays de l'Afrique centrale. La RDC, surtout dans sa partie Est, vit des guerres depuis plus de 20 ans, des guerres à répétition. Je ne voulais pas mettre ici des photos, des images, parce que c'est très atroce. Ces guerres qui tournent autour du pillage des ressources naturelles, de l'or, des diamants, des cassitérites, etc. Donc ici, vous comprenez que ce sont des coins du pays où les multinationales s'implantent pour mettre des troubles, pour alimenter des conflits entre tribus, afin de piller des ressources naturelles et voilà, essayer mais tout ça a des conséquences sur la population directement parce que c'est la population qui en pâtit, elle ne profite à rien sur tout ça. Mais cette situation n'est pas seulement à l'Est, elle est générale, elle est généralisée dans des territoires où il y a des intérêts économiques. Il y en a au Katanga, il y a au Kasaï, et par-ci, par-là, parsemés dans plusieurs provinces de notre pays, la République démocratique du Congo. La population de ces territoires est plus exposée à des problèmes de santé mentale parce qu'elle vit dans des traumatismes exagérés. Et cela se manifeste même dans le comportement de cette population, le comportement où la population est devenue hostile même par rapport à certaines politiques qui peuvent construire l'État. Hein, c'est par exemple où, quand il faut dire que la mission des Nations Unies accompagne le développement du pays, mais la population s'est dit non parce qu'elle pense que la mission des Nations Unies contribue aussi à alimenter ces guerres et finalement qui finissent par créer des traumatismes au sein de la population. Ce sont des comportements de la population qui sont créés à partir de ces choses à répétition, de ces traumatismes exagérés. J'ai essayé de distinguer quelques sortes de traumatismes où j'ai trouvé des traumatismes qui sont à la base de situations socio-économiques, des situations de conflits dans le pays. Ici, il y a des vols à main armée, par-ci, par-là dans le pays. Il y a des violences sexuelles et domestiques. Vous imaginez L'exemple seul au Kasaï, c'est une province de notre pays. Entre janvier et mars 2001, 1373 femmes ont été violées. Et parmi ces femmes violées, 60% sont délaissées par leur famille et par leur mari. Malheureusement, ces femmes vont avec les enfants dans la nature et deviennent des mendiantes et tout cela. Tout ça sans de politique de réinsertion sociale capable de ramener ces femmes dans la société. C'est un pays où des tueries à la machette, là je parle de gangstérisme, le gangstérisme même de la jeunesse, c'est-à-dire la jeunesse qui s'est transformée en gang parce que la pauvreté est tellement accrue que les hommes, les jeunes, pensent qu'il faut créer des gangs pour survivre. Il y a aussi des cas d'enlèvement. Ça, c'est un peu rapproché à ces tueries à la machette, à ces gangstérismes, etc. Le deuxième palier de traumatisme, ce sont réellement des traumatismes qui sont liés à la guerre directement. Cette insécurité accrue, ces différentes tueries, ces massacres, ceux qui connaissent Beni, je vais partager dans le chat quelques liens. Ceux qui connaissent Beni, par exemple, ils vont voir, c'est une population, mais il s'est installé une sorte aujourd'hui, on pense que ce sont des djihadistes, etc., qui tuent à la machette, et c'est là chaque jour. Vous imaginez cette population qui vit dans ces climats-là depuis plus de 10 ans, etc., comment elle va se comporter? Ce sont des traumatismes, pas seulement des familles qui sont massacrées, mais de toute la population qui vit dans ces coins du pays. Les violences basées sur le genre, les indicateurs sont toujours à la hausse, malgré plusieurs interventions des ONG et des partenaires multilatéraux. Par exemple, entre janvier et juin 2020, on a recensé plus de 27 000 cas de violences basées sur le genre. Vous imaginez, c'est tellement accru qu'il faut qu'il y ait de bonnes politiques de prise en charge de la santé mentale, de bonnes politiques de réinsertion des personnes, des victimes directes. Je suis allé plus loin pour voir et même les grossesses précoces. C'est aussi dans la même ligne où la population vit dans des traumatismes. Les jeunes filles qui n'ont plus de lignes éducationnelles, donc des lignes qui peuvent les amener dans une bonne éducation, s'amènent dans cette vie où elles deviennent grosses à 14 ans, à 15 ans, à 16 ans, et c'est là, ça crée tout ça dans des familles, ça crée tout ça dans la communauté, mais on se pose la question, quel est maintenant l'avenir de cette communauté qui s'accroît sans encadrement au niveau politique. Ce sont des milieux où l'enrôlement des enfants dans de groupes armés est réel. Dans la seule province du Nord Kivu, plus de 33 000 enfants ont intégré les milices armées. Même s'il y a des ONG et d'autres partenaires qui aident à leur démobilisation, à leur réinsertion dans la communauté, mais ça reste un problème réel parce qu'il n'y a pas de politique claire, il n'y a pas de stratégie nationale claire pour tous ces problèmes-là. Les derniers paliers de traumatisme que j'ai eu à initier, ce sont des catastrophes naturelles et des épidémies. L'éruption volcanique, comment est-ce qu'on prend en compte cet aspect des personnes qui doivent se déplacer, des personnes qui manquent de l'eau parce qu'il y a eu éruption volcanique, qui manquent de l'électricité parce qu'il y a eu éruption volcanique, qui perdent souvent leur maison, etc. Il n'y a toujours pas de prise en charge claire. Ce sont des gens qui viennent, des partenaires qui peuvent venir pour essayer de pallier, mais la prise en charge n'est pas efficace. Nous avons des inondations, mais aussi nous avons la pandémie COVID-19 qui a créé beaucoup de traumatismes dans notre pays, même si ça n'a pas été très fort en Afrique, la COVID-19, mais c'était une pandémie qui a créé beaucoup de traumatismes. Premièrement, parce que la prise en charge au niveau de la RDC n'avait pas été efficace immédiatement. Les respirateurs qui étaient insuffisants, au fait que plusieurs personnes sont mortes sur les lits de l'hôpital parce qu'ils ont manqué de respirateurs, parce qu'ils ont manqué de prise à charge efficace. Et à la fin, je parle de la maladie à virus Ebola qui a ravagé le Congo à plus de 14 fois de suite. Ce sont des situations qui ont créé des traumatismes accrus. Ces personnes qui ont été contaminées et qui sont guéries, comment on a organisé leur réinsertion dans la communauté? Ce sont des personnes qui doivent être suivies parce que s'ils ne sont pas suivis, ça devient contagieuse maintenant parce que on dit que la maladie à virus Ebola reste surtout dans le spermatozoïde pendant plus d'une année et dans le sein de la femme pendant plus autant d'années. Donc, il faut un vrai suivi pour que tout cela revienne, pour que cette santé mentale revienne à la normale. Mais le dénominateur commun ici, c'est la pauvreté. Vous imaginez, nous sommes dans un pays, ça je parle du Congo, en 2018, où environ 73% de la population du pays, soit plus de 60 millions de personnes, vivent avec moins de 2 dollars par jour. Alors, à cela, nous nous sommes posé la question, quelles sont les réponses? Quelles sont les réponses du gouvernement et comment est-ce que les réponses sont organisées au niveau interne? Le ministère de la Santé aujourd'hui n'a pas de stratégie nationale claire par rapport à la santé mentale. La seule stratégie qui existe, on nous parle d'une stratégie de prise à charge de maladies mentales, mais pas réellement de la santé mentale. Vous voyez, parce que c'est deux aspects différents. Malheureusement, même si il existait de politiques nationales en création, comme nous disent les experts du ministère, malheureusement, aucune norme d'application ni de politique de mise en œuvre n'est clairement définie sur le plan national. Aucune intervention durable, sérieuse, malgré les indicateurs qui sont toujours au rouge et à hausse. Le gouvernement ne compte ici finalement que sur les efforts des partenaires multilatéraux et donc ne contrôle pas sérieusement ce secteur. C'est pourquoi il y a maintenant des organisations internationales, ce n'est pas toutes les organisations qui viennent pour aider, il y en a aussi d'autres qui viennent pour venir faire leurs projets, mais sans suivre réellement le changement. C'est pourquoi maintenant, de telles organisations viennent avec beaucoup d'argent, mais rien ne change. La deuxième partie de la réponse, ce sont les organisations, les ONG. Les ONG ici, plusieurs ONG ont développé des projets pour encadrer les personnes en situation de santé mentale très menacée. Par exemple, nous avons des ONG qui identifient les victimes de viols, de violences basées sur les genres, qui organisent leur encadrement psychologique dans des maisons, dans des centres d'écoute et dans des hôpitaux construits pour ce faire, et qui organisent leur réinsertion dans la communauté. C'est par exemple les filles violées dans des milliers de guerres, les victimes de viols militaires sont ramenées pour être suivies dans des centres psychologiques de certaines ONG, et à fin de compte, on imagine des kits de réinsertion, c'est soit fournir un peu d'argent, donner un peu de moyens financiers et peut-être quelque chose pour la survie de celui-là, pour qu'ils ne se sentent pas lésés dans la communauté. Ça, c'est du côté de certaines ONG réellement qui... Et c'est là-bas que provient une grande réponse.
Sorry, Billy, could you wrap up, please?
Oui. OK. Voilà, il y a une troisième réponse. Ça, je veux parler maintenant de l'expérience de l'Étoile du Sud, par exemple. J'en ai pris que 2 expériences. Je vais partager le lien dans le chat. L'Étoile du Sud, c'est une ONG de droit congolais, justement, qui est membre du PHM. Par exemple, pendant la pénurie d'eau due à l'éruption volcanique dans la ville de Goma, l'Étoile du Sud a activé les comités d'eau et a distribué gratuitement de l'eau à la population, a mis des systèmes où la population peut être à mesure elle-même de continuer à acheter de l'eau et à distribuer cette eau-là à la population. L'Étoile du Sud a organisé et a sensibilisé les masses populaires, surtout pour la protection des enfants de moins de 5 ans contre la malnutrition. Vous imaginez, quand il n'y a pas de l'eau, c'est qu'on est face à des diarrhées qui peuvent survenir, mais aussi les enfants peuvent facilement attraper la malnutrition, etc. Nous avons aussi amené la clinique mobile pour accompagner psychologiquement le malade, essayer de soigner certaines maladies et essayer d'accompagner des personnes qui ont été traumatisées par cela et les réinsérer dans la communauté. J'ai parlé aussi de l'expérience sur la guerre, ça c'est à Beni, où nous avons développé un projet pour identifier les cas de violence basés sur les genres, les cas de violence sexuelle. Et nous avons formé la population dans des comités populaires pour la paix afin de créer des espaces de dialogue entre la population et les autorités pour que la population aussi participe à la recherche de la paix dans ce coin-là. Tout ça dans le sens d'aider afin que ces éléments, afin que la santé mentale ne fût-ce que soit prise en charge et tout petit peu. Mais que faire pour améliorer la santé mentale? Ça, ce sont nos conclusions. Nous avons pensé qu'il est important d'inclure la santé mentale dans le paquet de soins de santé essentiels centrés sur les patients. Nous le savons bien que dans ces paquets, il y a la prise en charge des handicapés, etc. Mais nous voudrions que tous les contenus de santé mentale soient inclus dans le paquet de soins de santé essentiels centrés sur les patients. Nous avons pensé qu'il faut renforcer les systèmes de formation sanitaire sur la santé mentale. Il faut que les structures sanitaires soient en mesure d'informer, au-delà de la prise à charge, soient en mesure de former pour que l'État comprenne globalement les choses, comment elles évoluent. Mais en fin de compte, il faut mettre en place des stratégies nationales réalistes qui luttent pour cette santé mentale. Ce sont des stratégies qu'on peut mettre au niveau national, qu'on peut décentraliser dans des DPS, donc dans des directions provinciales de la santé, et aider de lutter pour l'amélioration de la santé mentale. Nous avons pensé aussi au renforcement de la participation communautaire, de la participation de la communauté aux activités de santé mentale et renforcer les systèmes communautaires par la mise en place des réseaux de soutien social. Il faut que l'État essaie de mettre en place des réseaux de soutien social à ces personnes-là. C'est souvent des personnes qui ne veulent pas dire leur cas. Une personne traumatisée, il faut l'identifier. Mais si vous pensez que c'est cette personne-là qui viendra réellement annoncer qu'elle est traumatisée, alors ce traumatisme va rester dans la population et ne saura pas les dénicher. Il faut donc mettre en place des réseaux qui soutiennent cela. Et à fin de compte, contrôler et encadrer les interventions des partenaires multilatéraux, comme je l'avais dit avant, que ce n'est pas tous les partenaires qui viennent dans le but d'améliorer, certaines viennent dans le but de faire, mais ne pas suivre les améliorations, ce qui ne contribue parfois à rien, car les indicateurs restent toujours au rouge. Voilà un peu ce que j'ai préparé pour ma petite présentation. Je vais directement partager certains liens dans le chat. Merci beaucoup.
Thank you, Billy, for an excellent presentation that really gives a macro overview of the ways in which something like mental health is not solvable only within the medical system, but also that we need community support, and then also attention to bigger factors like conflict, violent conflict, war, and also gender relations and the way in which those relationships shape vulnerability and violence. So next, I would like to welcome Monika Kosinska. She's the head of the Economic and Commercial Determinants of Health Unit at WHO. And she's going to speak to us about addressing commercial determinants of NCDs, making a start. It's something that was quite prominent on the agenda at most recent assembly. So Monika, welcome, and the floor is yours. Thanks.
Thank you very much, Lauren. I hope you can hear me okay. I'm just going to start my presentation now. So first of all, thank you very much to all of you. Well, thank you very much to the organizers, and it's a great pleasure to be able to join you here today and for this very interesting and very timely discussion on a number of very important issues. What I wanted to go through with you in quite brief time that's been allocated towards me, the work that has been recently initiated by WHO on the commercial determinants of health. So this is a new program of work on which I am privileged to lead, and we have been established about 18 months ago. And this is, of course, very pertinent, given, as you said, some of the recent discussions, but also in light of the work that you are and all the colleagues on the call are undertaking around us every day. So just a short introduction. I don't think I need to explain to anyone on this call the importance of the rise of commercial determinants. Many of you are very active in this on a daily basis. However, the concept, if the concept is not new, perhaps the terminology is newer for us. It has only been in use, in common usage for the last 10 years or so, although the work is much longer than that and rooted largely in the NCD agenda, but not only. And it has risen, or our understanding of commercial determinants has increased as the burden and the challenge has increased, and these two have certainly go hand in hand. Some will say, or some have said, that this is indeed the commercial determinants underlie the main public health crises that we have seen over the 21st century, not only NCDs, but also the COVID pandemic, climate disasters, occupational illnesses, mental health, forgive me, environmental exposure, but also injuries and death in itself. And however, in our, it is, although the conceptual development perhaps is not so relevant for our daily work, it is very important for us to understand and to see the commercial determinants as a key social determinants of health. It is an underlying driver and an underlying cause, as well as the pathways in which it manifests across different populations and differently across different groups globally. And all of this has to be seen in the context that we are seeing across the development agenda of the rise of the private sector as a multi-sectoral partner. And this dichotomy, some may call it, of the challenge that we face, the health challenges that we will face, the role of commercial practices in driving those challenges, with the rise of recognition, inclusion, and partnership with the private sector itself, is one of the areas that we need to walk the line of when we look at this from a WHO perspective. And this is the context of the program that I'm privileged to run from WHO headquarters. This comes not only, as I said, in reflecting the rise in both the impacts, but also the private sector and development, but it's very much rooted in building on existing WHO work and evidence across the various, what we could call vertical program areas. And we cover the spectrum of corporate behavior, from the supply chains all the way through to regulatory influence, and I'll talk a little bit about that later on. And the social determinants framing allows us to take a power, equity, and governance lens to this work, which of course is crucial, not only to understand it, but also to start to think about what we can do about it. And I've included here one of the definitions that is in usage, a working definition that we also use, that the commercial determinants are, broadly speaking, those activities that the private sector affect the health of populations. And you can see that this is both a very inclusive definition, a broad definition, but also, like all of the determinants, a neutral definition. And there are two main deliverables that we're working towards, which I wanted to share with you today. One is the WHO, the first WHO global report on commercial determinants of health, which we hope to have launched in 2024, and a global conference on commercial determinants of health, where we will encourage the submission of abstracts and participation from across different areas of public policy, civil society, and beyond. So I very much encourage you to participate in that, which we hope to hold towards the end of next year. There is a WHO definition of commercial determinants in addition to the one that I mentioned earlier, which is the one that is by Mani and all, and that we use as a shorthand, as a working definition. But the main definition was published in the WHO Director General's report to the Executive Board, and also in a UN Secretary General's report on NCDs presented to the UN General Assembly, both in 2018. In order to move a little bit more into what it is that we're talking about here, it is of course about understanding impact and understanding risk, and we can see that in four main areas. So with two areas which are largely looking at the actions of commercial actors or commercial practices, and two that look at the impacts of these actions. So if we take the actions themselves, we've divided this into corporate business operations or market activities. So moving beyond just the product or just the products themselves, but looking at the practices around retail, sales, marketing, but then also beyond in employment practices, unionization or impact on unionization, property management, logistics, distribution, and as well as the monopolies, impact on monopolies and market dominance. And then the second, which we have called corporate citizenship or personhood, but can also be called captured under non-market activities, is really how the commercial actor behaves as an institution, how it interacts in public spaces and public discourse, public policy. So corporate social responsibility, public relations, political activities, lobbying, tax contributions, and also third-party business association activity, and the relationship in some cases with civil society as well. And these two drivers, or these two areas of actions, impact in two different ways, as all of you here know. I don't need to explain this to any of you, I'm sure. The first, of course, is the impacts on the determinants, both physical, social, cultural, but also behavioral. And then the second is the impact on the regulatory system and processes itself. And it is the combination of this complexity which then leads us in the direction of some of the outcomes that we can see. And if we focus on how the commercial determinants drive NCDs and broader public health challenges, this is where some of the questions of power come in. And I've just included here the framework or the diagram proposed by Lima and Galea, which looks at 5 vehicles of power that are used to exert influence: the power over the political environment, over preference shaping, the knowledge environment, the legal environment, and of course the extra legal environment. And so as part of our work to really understand this and take a more systematic approach to commercial determinants than perhaps WHO has done before. It is not a new area for WHO at all, as many of you know, but this is the first time that we have a focused team, a focused unit that is looking at this across the organization more broadly and across different public health priority areas more broadly. And as part of that, we held an expert consultation. We held 2 last year and 1 this year, and 4 main challenges were identified there that we need to keep under consideration when thinking about this from the WHO perspective. One is how this fits into the broader economic and financial environments. 2, the importance of understanding where the costs land and where externalities lie, on maintaining an equity lens and ensuring that the focus is on outcomes, and then of course identifying risks and the management of conflict of interest. And so just a little bit more around the program of work. I mentioned this earlier on, that the that our focus here, or our attention on the power, equity, and governance aspects of this, and the scoping that we've been undertaking, the dialogues that we've been having underway. The first global report is an opportunity for this to come together in practice, and the objectives of this report are to clarify some of the commercial determinants concepts and terminology, to present the case for action, to synthesize the existing global evidence both on public health but also on health equity impact, and then to support countries where to what extent possible with evidence-informed policy recommendations. And the activities largely in our relatively short time has been focused on advocacy, which is one of the main feedback points that we received from our stakeholders, from the different communities that we've spoken to, including, of course, with the member states. And that is that the concept of commercial determinants, so taking a commercial lens on some of the common problems across the board, as a way to strengthen and to understand this in individual areas where there's a lot of work that's already been underway, whether that's tobacco, alcohol, food, and other areas. And here to this effect, we have a WHO topic page, which was put out earlier this year, a fact sheet which I invite you to access. We have a webinar series which is also available for participants publicly, that covers from the concepts of commercial determinants to how we measure it, to the role of civil society in addressing commercial determinants, which is of course very important, and other areas of interest. And then finally, the work that is underway at the regional level, because I think like many public health areas, the context and the regional specificity is very important. Commercial determinants look different depending on where you're sitting globally, and both the challenges, the dynamics, and the flows. And so the work that is underway in the WHO regional offices on commercial determinants is very important. The office in the Americas has started a series of dialogues and is working towards a regional paper, for example. In the European region, they've taken the disease lens to commercial determinants with the publication of the EuroHealth journal you'll see here, which looked at commercial determinants of cancer control policy, from prevention through to screening, treatment, and all the way to palliative care. In the WHO African region, there was a review of commercial determinants that has been undertaken, which looked at issues, so for example, from a human rights perspective. And in Southeast Asia, the work is underway to see how this can be integrated into the social determinants discussions that are going on. But I realize that I'm now close to my time, so just before I close, there are a number of resources from outside which are underway. It's still in development. It is a priority for us is, of course, coherence across the organization, and one of the priorities for my team has been to map and to understand what is where the synergies and the intersections are with the different policy developments that have been underway, including the WHA. But I know that we have another speaker who's going to discuss that now amongst us. So just without further ado, I would like to say thank you very much again. And wish you all the very best for the rest of the webinar.
Gracias, muchas gracias, Mónica, por esta presentación sobre los determinantes económicos y comerciales, uno de los desafíos más grandes en materia de entender por qué los desenlaces en materia de muertes y enfermedades con respecto a los problemas de las enfermedades crónicas. Muchas gracias por esta reflexión que tendrá que profundizarse porque es base de las discusiones de política en materia de prevención y de promoción de la salud en este campo. Invitamos a nuestro próximo presentador. Se trata de Anton Sundberg, quien nos va a hablar sobre los desarrollos de la política en el campo de las enfermedades no transmisibles en la Asamblea de la Organización Mundial de la salud número 75. Sundberg es estudiante de medicina de Goethe University en Frankfurt, Alemania. Quiero además decir que en esta moderación estamos colaborando conjuntamente la doctora Lauren Paremoer y yo. Así que pues ustedes la han visto y estará introduciendo a otros speakers en lo que sigue. Sigue adelante, Anton, por favor.
Yes, hello everyone. Thank you very much, Roman. I'm very honored to be here and to be able to give an insight from the WHO Watch team from the recent World Health Assembly. I will take a lens that kind of like has the commercial determinants of health perspective in order to get through in time and at the same time give an overview. So this was the program for this year's WHA and a follow-up to the political declaration on the prevention and control of NCDs. And it was a lot of documents and it covered a wide range of topics. So just to give you a short overview, there were some draft recommendations, for example, for strengthening and monitoring diabetes responses, then on the prevention and control of NCDs in humanitarian emergencies, which was quite a new topic that came out of the COVID pandemic, and then epilepsy or obesity. And at the same time, there were some progress reports, for example, on cervical cancer or draft work plans on the global coordinating mechanism. So kind of like a very, very diverse set of documents. And this is just to give you a short overview, basically. The starting point was, in a way, when we went through the documents, that it's not going quite well. So for example, covering obesity, it says, this is a quote from the documents, all countries are off track to meet the targets. Concerning cervical cancer, it's at a global HPV vaccination rate. HPV infections are a major risk factor for cervical cancer. That it has not only stalled, but fallen. And a little bit connected to that, because both of them touch upon an issue that relates to access to medicines also, was on diabetes, where it says, never have we had so much knowledge on the disease itself and the possibility to treat so many people, and yet it is not happening. And a lot of people are not receiving life-saving treatment for diabetes, which is connected to insulin and the access to insulin, among others. Right, and then the point that I mentioned already concerning the emergencies and how the COVID-19 pandemic has had a detrimental effect on the NCD care, but also the diagnosis, therapy, which is one point, so the disruption of services. And on the other hand, that people who suffer from NCDs were shown to have a much higher risk of developing severe COVID. So it was like a double impact. And at the same time, we heard about that a little bit in the first presentation, that one risk factor, for example, like poverty, which is a major risk factor for many NCDs, has also increased due to the economic impact of the pandemic. So the general feeling was there are a lot of problems in this area. And I think from what we just heard in this wonderful presentation on commercial determinants of health, I think looking at all of these bullet points with that perspective, it touches upon like access to medicines, it touches upon the marketing of unhealthy foods, it touches upon no significant change in the trends for NCD risk factors, except for tobacco, but all the others are kind of like not going so well in the end. The approach of the documents was quite technical in our view. There was a lot on like monitoring and surveillance, and also what was just mentioned, this approach of taking in the private sector in multi-stakeholderism as part of the solution was very much pushed, and at the same time there was quite little on the risks of that in including the private sector with its sometimes diverging interests. So for us, reading through the documents, there was this elephant in the room, which were the commercial determinants of health, and how little they were being addressed in specifically interventions. Quite a positive approach to the NCDs and the documents that there has been this 4x4 strategy, which essentially means that there are 4 risk factors, which are tobacco use, harmful use of alcohol, unhealthy diets, and physical inactivity, which are quite heavily connected to commercial determinants of health, to marketing practices, to trade, and so on. And so that's the 4, and the other 4 are 4 diseases that are being impacted or promoted through these risk factors, which are cardiovascular diseases, cancer, diabetes, and chronic respiratory diseases. And what happened now, which was quite nice to see, is that air pollution was added as a risk factor, which is also, of course, linked to industry and private sector, to industry and the private sector, and an additional disease was added also, which is mental health and mental well-being, which was elaborated upon already. So now this strategy has been extended from 4x4 to 5x5, which is quite great. At the same time, while there is quite a good rhetoric on the whole topic, the documents are quite vague on how to tackle these risk factors. And what Roman also said in his introduction was that this individualization of NCDs is quite a problem. And we did not have the feeling in the documents that even if the commercial determinants and the underlying kind of like risk factors were being addressed in rhetoric, that lens kind of got lost as soon as it got into concrete interventions. There were these plans to strengthen monitoring for diabetes, or like recommendations to accelerate progress on obesity. And looking into that, we didn't really find something that tackled this elephant in the room, which was how to deal with unhealthy diets and the promotion of these by multilateral multinational companies. And at the same time, this multi-stakeholderism that comes up all the time. And while on some points, conflicts of interest are mentioned, there's very little, again, concrete ways that are being proposed on how to deal with these conflicts of interest that, in our opinion, are one of the main culprits in providing success to these strategies, and could, on the other hand, like lead to quite some damage if the private sector is included heavily in these strategies, but there is no security for how to deal with their potential conflicts of interest. So almost to conclude, I wanted to point out some positive things. I touched upon a couple of things already, which in general is that the rhetoric has kind of like changed and commercial determinants do get some visibility, which is, for example, through this inclusion of air pollution. At the same time, there's very little in the documents upon how this is supposed to be tackled and what the main problems are when it comes to air pollution. And I think naming this problem, connecting it to some industries, and then having a resulting kind of like intervention of how to limit this is at the current point still missing. Tobacco and alcohol are more nuanced in the commercial determinants, so they are being acknowledged. And in the case of tobacco, also tackled through the Framework Convention, which I think is quite a good blueprint for tackling commercial determinants of health. And as I said, also, there are some rhetoric on potential conflicts of interests, and that it's very important to address this issue, like in the NCD Global Coordinating Mechanism, this is being named. But again, there's very little concrete being said on how to do this. Then another example is there was a European obesity report from WHO Europe, which was outlining the commercial determinants of health quite heavily, and also cited quote unquote neoliberal and capitalist ideologies, which I think was quite far reaching. And the delegates of low and middle income countries at the WHA this year also touched upon commercial, social, economic determinants of health, and also the conflict of interests, and also calling on WHO to be more clear on how the private sector and industry should be involved in providing solutions for the NCD epidemic. Then also primary healthcare was really emphasized in a lot of the documents, and the need to embed NCD care into primary healthcare. But at the same time, it often goes hand in hand with universal health coverage, and we did feel that there was no kind of like clear separation between the two, so that might be something to be vigilant about. And then at the same time, there was a WHO resolution on health promotion and well-being, which in my view also plays into tackling NCDs, because there it's really about prevention and about health promotion, which should, in my view, also include protecting communities, individuals from commercial interests that are actually detrimental to their health when it comes to the marketing of, let's say, tobacco or alcohol or unhealthy foods. And then another point worth noting.
Sorry, Anton, 1 minute. I know you're almost at the end.
Yeah,
but just
last sentence, just that the, thank you, Lauren, that the scientific evidence is really piling up on also the effects of addressing these commercial determinants of health. And yeah, I think I'll conclude with that, and also of a picture of the WHO watching team. And also these t-shirts, let's say, wrap it up in my view that it's about walking the talk for WHO on the commercial determinants of health. Thank you.
Thanks, Anton, for an excellent presentation, and also for all the watching of the discussions and debates at WHA. I think your presentation clearly highlights this tension between acknowledging industry, commerce as a driver of poor health outcomes, and then the tension with also trying to figure out how to include them in solving the problems. So that does lead to difficulties sometimes in walking the talk. Next, it's my pleasure to introduce Sundar, who is a member of PHM steering committee, and also the previous global coordinators of PHM. And he will give us a kind of big picture overview of NCDs at WHA 75. So very much building on what Anton has done. Sundar, the floor is yours.
Thank you. Anton has made it much easier for me. I've taken you through it once. I'm going to actually take you through it again, but highlighting certain aspects of these. Now, one of the points that I want to sort of thing is that this is not something that starts immediately in this World Health Assembly. It has a background, it has a history, and if you really need to understand it, there is a resource that People's Health Movement has, which is what is called as the WHO tracker, that provides a quick recollection of the entire history of how these developed and the twists and turns. And the most recent one is there on the last line, where there is a detailed PHM comment, there are diverse reports and an update. Now, in some sense, this is 280 pages of reports and proposals, and our own comment is 28 pages. So, in fact, what I am using this time for is to urge all of you in the audience to actually make use of this immense resource that has been created over 15 years by the People's Health Movement. You see over here this WHO tracker. In the home page, you will have access to WHA 75 and the executive board of all the meetings in the last 10 years, and you can see our each resolution and comment. In the diverse report, you have a sort of background. For example, this NCDs, a chronology is there in the diverse report. And this is developed as part of the WHO Watch. One part of it is the watchers that Anton presented. And this provides an easy access to the relevant documents, and do visit it. And now we also use it as a major way in which we reach out to our 70, 80 countries with a summary of what is the basic issues involved and how do we leverage it in the countries themselves. So this is the update that is circulated over here. So this WHO tracker, what it has said is what I am presenting to you in brief. As Anton said, this time there have been 5 or 6 new strategies unrolled. One is on diabetes, which is an elaboration. One is on oral health, which is completely new. Epilepsy, the earlier assemblies gave a mandate for this assembly to bring together an action plan. And we now have a plan on epilepsy and other neurological disorders. On the harmful use of alcohol, there is a comprehensive strategy on obesity, plus a review of 3 ongoing things: cervical cancer, mental health, tobacco control. There were also overall roadmaps. The draft implementation plan of 2023 to 2030. Remember that this 4x4 strategy that they were talking of was supposed to end at 2023. There was an action plan which was to end at 23 that has been extended. And the review of what it did was part of it, and the prevention mechanisms for the future. So these are the things that together were presented in the World Health Assembly. Now, as Anton said, if you were to summarize what the report said, the report card in one word, it was very disappointing. No country is on track to achieve its voluntary goals, and only a small number, because these targets are set by themselves, only a small number even honored their process to commitments towards getting there. There has been some reduction in mortality for the common NCDs, but premature mortality has increased. And you must remember that as actually the high-income countries tend to do better, they eventually, people die, they die of NCDs, they die at a much older age. What you are actually disguising is that in the LMICs, there has been a huge further increase in mortality. So far from holding the line, there has been a worsening, if you read it carefully, across the LMICs, and the inequity between the developed world and the developing world has just sharpened. And progress has been limited to rather administrative measures, and equity is almost missed on the whole issue. However, one of the positive developments is this whole 4x4 matrix has a real problematic one. It's very restrictive. It has an underlying assumption that 4 or 5 behavioral features have to be managed. It limits from your earlier selective care, which was too narrow a package. You have just managed to increase it to a slightly larger package, and it didn't work. As a result, all the problems of selective care came to it. Now, adding the 5th one, mental health, which was sort of overdue, and air pollution, which was sort of missed in the first one, is really no big deal. But in 2018, there was a conscious move that you need to have a further broadening. And this whole 4x4, 5x5 is not true enough. And therefore, you have across the board, some of these have moved in the regional conferences. For example, CRO conference on eye, ear, epilepsy, neurological diseases, hemoglobinopathies, chronic kidney disease, oral health, skin disease, harmful use of alcohol, NCD in emergencies. There's a much greater broadening. The whole understanding of NCDs has improved. We have now better burden of disease estimates. More countries are reporting on it, because otherwise we had dumbed down to reporting only IMR and MMR. Population-based strategies for a number of NCDs have been delineated for the first time, and that has been of great use. And there has been some call for integration and an acceptance of the lack of progress in NCDs. And in some sense, what it really helps is most of the LMICs, including countries like India, are stuck with very narrow selective packages. And this sort of upfront presentation of all these strategies provides the space for countries to expand. Now, I give you an example of the delineation that has been done. For example, in diabetes, when you put a public health strategies, this sort of indicators, 80% of people with diabetes should be diagnosed. You know, from Tudor had the theory of Hall's. Only 50% or less are currently diagnosed. In India, it's almost 1 in 3. And 80% of those who are diagnosed have good control of glycemia. Now it would be less than 50%. And those who are diagnosed with hypertension, that the next one is not diabetes, but hypertension, have good control of blood pressure. Also, those with diabetes, and then those receiving statins. And the last one where I'm going to put some emphasis is 100% of people with type 1 diabetes and quite a lot with type 2 should have access to affordable insulin and blood glucose self-monitoring. Imagine 100 years back, insulin is discovered, yet there's not almost no primary health center in the whole South Asia, Southeast Asia region would have insulin. All of India doesn't certainly have that. So at some point, the availability of it, and when you come, and this is what we are going to the actual provisioning of insulin, such a declaration is of very little progress, because the real bottleneck is the affordability of insulin, even for a government, and the ability to deliver it across these place issues. Now, this exercise, all I'm saying in this slide is this exercise having been done for a number of diseases really tries to break down what universal healthcare implies. And that, I think, is the big thing that it puts down on paper what it really means. But let me look at the limitations. One limitation, well, air pollution got added on with a very inadequate way and understanding of what can be done for it, but okay, sort of. But what is still missing is that the entire road of psychosocial stress, whether it is alienation, whether it is unemployment, whether it is the financialization of the household economy, by which I mean every house is in debt. You have to repay debt, the debt collector is the door. These sort of factors that relate to poverty and social stress, there is enough evidence that these are major contributors to all the NCDs, but these don't get even mentioned because they are not within your complete matrix, perhaps on this excuse that they are not preventable. We don't know exactly why they are not preventable, but you have this whole factor that a huge amount of risk factors are left out in this 5x5 matrix, and we need to really question that whole thing. And war and displacement as a huge contributor to stress, and the way stress acts, the commercial determinants of NCDs, they started looking at it. So I think this is one big limitation on that. The role of corporate power has...
Sundar, there's 2 minutes left.
Right. The role of corporate power has already been discussed across the whole area. The trade barriers, which are a major problem, are already discussed. This is also a major area. on this. And here again, we need to look at alternative things. And every one of these, if you look at insulin, I described diabetes. The same problem holds for the whole range of neurological drugs, cardiovascular drugs, HPV vaccines, new screening technologies, whether it's for cancer cervix or for different diseases. Every one of them requires an entirely different regime of innovation, manufacture, procurement, etc. And finally, you need a comprehensive primary health care. And this whole context over here is this tension between UHC and PHC. You can see the WHO as a structured, what I call a structured policy incoherence. It says two things. One line, it will say it must be integrated as a freely available thing across the place. In another line, it should be saying they have not yet packaged it into a UHC for a purchase. In some places, it's the UHC that will be emphasized. In other places, for example, in neurological diseases, it's all about a priced package included into UHC. But when it comes to epilepsy, it's all about inclusion in a network of primary care providers. This entire confusion is part of the reason why we make no progress on NCDs. And you really must look at the fact that the design of health systems is one of the reasons why we are not making progress. And when you talk of universal care, you need this workforce development. So if you need, let us look at, say, mental health, you need psychiatrists, you need community level providers. In between, you need physicians who can manage a mental health disease. You need people who are caregivers. You need a whole type of workforce. And that's true for, say, you're looking at eye, whether it is optometrists or ophthalmologists or in between community level eye care workers. There is no inkling of an approach towards this. We are still far removed from understanding that what the implications of primary care in terms of workforce development are. And again, therefore, if from 2013 to 2023, we have drawn a blank, we will continue to draw a blank unless we are able to engage with this. And that's why the PHM has clearly said that many of these statements, well-intentioned though maybe, they should really be withdrawn by the WHO and they should go back to addressing some of these issues. Community participation, the role of traditional health systems, these are just missing. And equity, and this is most surprising. Whereas equity, they swear by it, this leaves no one behind is not good enough. It's not just a question of prevalence in different people, in access to healthcare, in exposure to risk factors, in the organization of services. Many of the documents are just missing it. The worst particular document among this is the public health emergencies. There's a simple fact. If in normal times you are not able to manage NCD, you can't manage it in an emergency. How much intelligence do you need to know that? But yet the whole system is trying to find a way in which you can have an essential NCD kit that you can deploy during an emergency. So there are issues in which these have to be taken for. Therefore, I think that the PHM calls on member states to, so when we come back to our countries, we don't just criticize the thing. In fact, we say that at Geneva, you agreed to all these programs. Why aren't you rolling it out? But we also need to see that all this World Bank and the IMF are consistent with this and what they are pushing, because they agree to it there also. And the role of civil society, LMIC, government representatives, the role that, and we do need, and this particularly calls for policy analysts to work with the tracker and the WHO Watch program and with our thematic circles. So I'm happy that more than 25 countries are attending this today. I look forward to a continued engagement in the thematic circles and governance thing. This sort of analysis should be taking place worldwide. So thank you. This is the sort of overall structure within which the PHM's agenda on global health governance and on thematic circle moves forward. Thank you.
Gracias, Sundar, y gracias a la intérprete. En todo caso, hemos comprendido muy bien el trabajo de interpretación que has hecho. Sundar, yo creo que lo que has planteado caracteriza muy bien los desafíos que continuamos teniendo frente a las enfermedades crónicas no transmisibles. Los avances se perfilan en donde se están haciendo los esfuerzos, en el manejo de factores de riesgo, particularmente desde el campo clínico. Pero el cuello de botella, como has dicho, está en lo que la Organización Mundial de la Salud denomina determinantes estructurales de la salud y lo que en América Latina llamamos procesos de determinación social de la salud. Ahí está el problema y eso es el desafío que tenemos a escala global en cada país y en cada región. Gracias por esa presentación que ilustra muy bien cómo deberemos seguir luchando para lograr avances en la salud para todos y todas. Invitamos ahora a nuestra compañera Graciano, Andrea Graciano de Argentina, quien nos va a presentar una experiencia muy concreta frente a cómo en nuestros países se ha avanzado o no en revertir la epidemia de obesidad. Y la pregunta que ella nos trae en su presentación es si las políticas son o no adecuadas. Y yo creo que esto hace un vínculo muy fuerte con los análisis globales sobre las políticas en el campo de las enfermedades crónicas no transmisibles. Andrea es del Movimiento de Salud de los Pueblos en Argentina, pero también está vinculada a la Universidad de Buenos Aires y a la Unión de Científicos comprometidos con la sociedad y la naturaleza en América Latina. Gracias, Andrea, por aceptar nuestra invitación y tienes la palabra.
Bueno, muchas gracias por esta invitación y voy a intentar no hablar tan rápido como suelo hacerlo para facilitar la tarea de la traducción. Bueno, en primer lugar, agradecer, como les decía, y comentarles que no tengo conflictos de intereses económicos ni he percibido remuneración por participar en este evento. Bueno, poniendo un poco de contexto, entender que las enfermedades no transmisibles vienen aumentando y son la principal causa de muerte a nivel global. Más del 70% de las muertes son atribuibles a las enfermedades no transmisibles, pero esta situación es aún peor en la región de las Américas, donde más del 80% de las muertes se deben a estas causas. Ahora bien, las enfermedades no transmisibles relacionadas con la alimentación son una de las formas que adopta la malnutrición, que la Organización Mundial de la Salud ha agrupado en 3 grandes grupos de afecciones, y que también incluyen a las distintas formas de desnutrición y a la malnutrición vinculada a micronutrientes. El foco va a estar puesto en estas situaciones de malnutrición por exceso, sobrepeso, obesidad y enfermedades no transmisibles relacionadas con la alimentación, y entender que si bien la malnutrición adopta múltiples formas, la más prevalente es la malnutrición por exceso, que a nivel global el exceso de peso, que comprende el sobrepeso y la obesidad, afecta, digamos, tomando el caso de los menores de 5 años, ¿no? La región de las Américas se encuentra por encima de la media global, y no solamente eso, sino que es la región que tiene los valores más altos, ¿no? Y todo lo contrario sucede con las situaciones de malnutrición por déficit. A su vez, cuando analizamos intrarregionalmente, lo que vemos es que dentro de Latinoamérica, la mayor prevalencia, o sea, el exceso de peso viene aumentando a lo largo de los años, y la mayor prevalencia está en Sudamérica, comparada con la región de América Central y del Caribe, ¿no? Ahora bien, el sobrepeso y la obesidad son uno de los factores de riesgo metabólicos para la aparición de estas enfermedades no transmisibles, y dentro de los factores de riesgo también está la dieta poco saludable, que es donde voy a poner el foco. En ese sentido, comentarles que lo ideal es acercarnos a la alimentación desde una perspectiva sistémica, y cuando hablamos de sistemas alimentarios, podemos definirlo rápidamente, tal como lo hace este informe de UNICEF, como todo y todos los que participan en llevar la comida de la granja a la mesa, ¿no? O sea, los alimentos desde que se producen hasta que se consumen. Y si bien muchas veces se cree, digamos, que la alimentación depende de nuestros comportamientos como consumidores, es fundamental tener presente que en realidad nuestros consumos alimentarios están determinados por los entornos alimentarios en los que estamos inmersos, ya sea a nivel de nuestros hogares, de nuestras familias, o bien los entornos alimentarios externos, como los lugares donde estudiamos, donde vivimos, ¿no? Las escuelas, las universidades, nuestros lugares de trabajo, los puntos de venta, y por sobre todas las cosas también por la cadena de suministros de alimento, que es uno de los elementos de los sistemas alimentarios que generalmente no miramos. Y de hecho, este informe de distintas agencias de Naciones Unidas lo que ha mostrado es que los problemas de malnutrición de la región son precisamente el resultado de los profundos cambios que han afectado a los sistemas alimentarios, y son estas transformaciones las que determinan qué cantidad, qué calidad y qué diversidad de alimentos están disponibles para el consumo humano. Y dentro de las transformaciones, uno de los factores que ha traccionado esta modificación en los sistemas alimentarios han sido los cambios en los patrones alimentarios, ¿no? Con una característica en la región, que las dietas se están occidentalizando y los alimentos naturales y mínimamente procesados vienen siendo desplazados por alimentos altamente industrializados, que se comercializan listos para consumir, con una característica que es que tienen un exceso de nutrientes críticos, grasas, azúcares y sodio, y son productos que el Sistema NOVA y la Organización Panamericana de la Salud, entre otras agencias de las Naciones Unidas, han denominado productos ultraprocesados. ¿De qué hablamos cuando hablamos de los ultraprocesados? Bueno, hablamos de alimentos y bebidas envasados que tienen muchos ingredientes, la mayoría aditivos alimentarios, y de hecho tienen una característica que es cuando miramos los ingredientes, a veces tenemos productos como un jugo de durazno que no tiene durazno, ¿no? O sea, tienen poco o nada de alimentos reales, son muy sabrosos precisamente por los aditivos y los nutrientes críticos que poseen, y son dañinos tanto para la salud humana como para la salud ambiental. Y de hecho, las agencias de Naciones Unidas desde hace muchos años que vienen diciendo que para poder tener una alimentación saludable es necesario tener un sistema alimentario sostenible, y para poder lograrlo se necesitan una serie de regulaciones, como por ejemplo políticas fiscales, gravar con impuestos aquellos consumos que se quiere desalentar, ¿no? Aquellos productos cuyo consumo se quiere desalentar, subsidiar aquellos alimentos saludables cuyo consumo se quiere promover, implementar de manera obligatoria un etiquetado frontal y avanzar con regulaciones e idealmente prohibiciones de publicidad y otras estrategias de mercadeo. En ese sentido, son múltiples las políticas públicas que se necesitan para poder abordar esta problemática en su complejidad. Como región hemos avanzado con muchas políticas concretas en distintos países, y acá las fui marcando de color verde, pero la verdad es que necesitamos todavía muchas otras políticas que nos permitan aumentar la disponibilidad de alimentos saludables, y en ese sentido es clave apoyar la agricultura familiar, campesina, indígena, y promover circuitos cortos de comercialización, y que el agua segura esté disponible de manera gratuita en escuelas, instituciones de salud, en la vía pública, en los lugares de esparcimiento. En relación a las políticas, voy a ir mencionando brevemente algunos ejemplos de políticas con las que hemos avanzado, comenzando por una, que es el etiquetado frontal, y tomo esta porque si bien distintos países a nivel mundial han implementado de manera voluntaria distintos sistemas de etiquetado frontal, América Latina ha sido pionera en la implementación obligatoria de etiquetado frontal, que ha tenido distintas formas. El primer país en implementar un etiquetado frontal de advertencias ha sido Chile en el año 2012, lo reglamenta en 2015, y a partir de esta experiencia distintos países han ido implementando también de manera obligatoria distintos sistemas de etiquetado frontal de advertencia, la mayoría con una forma octogonal. Brasil lo aprueba con otro sistema gráfico. Los dos últimos países de la región en aprobar normativas de etiquetado han sido Colombia, que aún no ha reglamentado su ley, y Argentina, que ya la aprobó, la reglamentó y comenzó a ponerse en marcha hacia la plena implementación que está prevista para el año próximo. Y muchas de estas normativas, que son conocidas como leyes de etiquetado, leyes de comida chatarra, también contienen otras regulaciones, como por ejemplo regulaciones que prohíben la publicidad, y especialmente la publicidad dirigida a niños, niñas y adolescentes. En algunos casos, prohibiciones específicas, digamos, y en otras prohibiciones totales, como por ejemplo la normativa argentina, que prohíbe la publicidad, promoción y patrocinio de todo tipo por todos los medios y canales cuando estas acciones se dirigen específicamente a niños, niñas y adolescentes, ¿no? Y de hecho, esta es una publicación que... Sí. ¿Voy muy rápido?
2 minutes, please.
Ok. Bien, bueno, las normativas también han apuntado a limitar las estrategias comerciales que se despliegan en los envases de los productos, poniéndole un coto específicamente a ciertas estrategias, porque la industria alimentaria reproduce estereotipos de belleza y de género, pero luego despliega estrategias de pinkwashing o de nutriwashing, nos produce cáncer, pero luego nos convence de que está trabajando por su cura. Países que han implementado impuestos a bebidas azucaradas, que han mostrado que funcionan, por ejemplo, México con disminuciones de más de un 6% al año y de casi un 10% a los 2 años, países que están abogando actualmente como Colombia porque estos impuestos se transformen en ley, países que han avanzado como Chile, Argentina, y ayer México aprobó una regulación para poder contar con entornos escolares saludables, países que Argentina fue pionera en la regulación de las grasas trans, aunque luego los estándares mejoraron, la Organización Mundial de la Salud propone la estrategia Replace, todo el Mercosur había adoptado esa normativa, y recientemente, ahora en agosto, Argentina logró avanzar para tener un mejor estándar. Países que han avanzado con etiquetados que informan de manera obligatoria la presencia de organismos genéticamente modificados, como Uruguay, Brasil y recientemente Perú. Países que lideran avances regulatorios como México, con la prohibición gradual del glifosato hacia su prohibición total en el 2024, y la prohibición del maíz transgénico, y este punto es fundamental porque estos herbicidas, que nosotros desde la soberanía alimentaria les llamamos agrotóxicos, funcionan como disruptores endocrinos y también son responsables del aumento de la epidemia de obesidad. Bueno, hemos visto que la industria alimentaria despliega una serie de estrategias para intentar impedir o debilitar las políticas públicas que protegen nuestros derechos, y en contraposición, digamos, desde las organizaciones, el rol de la sociedad civil ha sido clave, y las organizaciones se han nucleado a nivel nacional, pero también a nivel regional, para poder abogar por estas políticas públicas, han documentado estrategias en alianzas incluso entre países, por ejemplo, este documento elaborado por un colectivo de abogados de Colombia junto con una organización mexicana. Necesitamos avanzar con muchas otras regulaciones, como por ejemplo lograr que el Código Internacional de Sucedáneos se transforme en ley para proteger el primer alimento soberano, que es la leche humana, y otras regulaciones como por ejemplo mejorar los entornos de las instituciones de salud que nos ofrecen, nos venden los productos que nos enferman, pero también nos lo ofrecen como parte de las prestaciones alimentarias que se dan. Esto, por ejemplo, es una foto en una sala de pediatría, y entender que la obesidad es una de las epidemias que contribuye, junto, por ejemplo, con el cambio climático, a esta sindemia global en la que estamos inmersos, y entender que los sistemas alimentarios son responsables de 1/3 de los gases de efecto invernadero que contribuyen al calentamiento global, ¿no? Y que estas mismas grandes transnacionales que enferman nuestros cuerpos, enferman nuestros territorios. Cuando miramos las principales empresas contaminantes de plásticos en el mundo, son las mismas transnacionales que producen ultraprocesados, pero a su vez despliegan estrategias de greenwashing, como por ejemplo ser sponsors de la Conferencia de las Naciones Unidas sobre el Cambio Climático. Y para cerrar, entender que siempre, siempre y sobre todo en los contextos más adversos, la salida es colectiva. Bueno, muchas gracias.
Thank you, Andrea, for an excellent presentation, and also the focus on specific policy measures that countries can take to resist and organize, at least in terms of the consumer end of things, better options, more information And hopefully that helps to lead to better health outcomes. But I like also your final point, which is that it's about collective action and working together. So thank you for that. Next, it's my pleasure to introduce Professor Mamoon Mostafi, who's joining us from Bangladesh. He's a professor of medicine and specializes in nephrology, and I'm happy to hand the floor to him. Thank you, Prof, for all your patience and for being with us today. Welcome.
Good evening, everybody. Am I clear?
Yes, you are, and we can see your screen. So we're just waiting for the slides to load. Thank you.
Okay. The organizers and the dignitaries of the session, in the next few minutes, I'll be with you. This
in the meantime, I can encourage people to please post your questions because we will have some 20 minutes for discussion. So please feel free. Thank you.
So thank you once again. Let me start. I'll be discussing with you regarding the policy changes in chronic kidney disease, the experience from my country, Bangladesh. As you all know, according to the Global Burden Disease Study in 2010, the CKD was a standing 18th cause of global death. In 1990, it was 27th. But over the next few years, there has been gross increase in the number of deaths due to CKD. And in 2017...
Sir, apology for interrupting you. Could you kindly put your slide up on the screen? Right now, we're seeing your menu. Thank you.
So the screen is not clear?
We see your file directory, but the actual PowerPoint is not loading. So maybe it's that you have to go to a different screen to share.
Yeah, I'm sharing the screen.
Okay, we can see it now. It says CKD global scenario. Thank you. Thanks,
Yeah.
Professor.
So in 2017, it has become the 12th cause of the total death globally. And in 2017, the global CKD incidence was 700 million. But as you see, in the 2022, it has become 843 million globally. So the incidence is increasing. And you will be surprised to see that the Greece, Israel, and Singapore, the most developed countries, they have got CKD in the 10th, among the 10th total cause of death. In India, a recent study has shown that very soon, the CKD death toll will become the 5th among the leading cause of death. So this is very important and paramount importance to highlight CKD in all the forums to discuss. In Bangladesh, a meta-analysis of 9 studies revealed that among the participants, 22% of the population has got the CKD incidence. And among the female, the rate is more than the male. According to the Bangladesh Health and Demographic Survey, 32% of the women, 19% of the men are hypertensive, 11% of both sexes are diabetes. Along with this, sedentary lifestyle of nowadays, the intake of fast food and dietary behaviors has complexed the situation much more. Not only that, a recent study has also shown that the poorer people are also having a higher risk of CKD. So that could be due to food adulteration, irrational use of drugs, herbal drugs, and many other things that could be due to post-infectious others. You'll be surprised to know that though diabetes is the principal cause of CKD, in our centers, still glomerulonephritis is the highest cause of end-stage renal disease. According to the latest WHO data in 2020, The total death due to CKD was 10,841. That leads to 16th position in the total death in our country. But Vital Statistics Survey of Bangladesh Bureau of Statistics revealed that in 2020, the death was 28,000, which was 10,000 in 2019. So in a year, it has been tripled. So that shows the magnitude of the problem are coming ahead. And as a result, here you can see that the CKD has mounted the 9th cause of death in 2020 in our country. And over the year, our hospital data shows that 35,000 of new ASRD patients get admitted for renal replacement therapy. But you will know that we have got 120 dialysis centers in our whole country that can account 10,000 patients to their waiting list. So as such, 66% of our patients do not have access to dialysis or transplant. At present, almost all the dialysis centers are profit-oriented. They cost about $20 to $50 per dialysis. The government dialysis services are free, but the numbers are quite insufficient. Here, Ganoswasthya Kendra, our dialysis centers provide dialysis at a rate of $5 to $20 per dialysis. And there are options of free dialysis for special needy peoples of the country. We have started the dialysis center in 2017. Here you can see that only 20,000 dialysis sessions have been done in that year. And over the last 5 years, last year we had more than 120,000 dialysis in a year. So here you can see the magnitude of the CKD, magnitude of the ASRD that has been prevailing in our country. Besides this, I like to highlight some of the NCD control program of the Ganoswasthya. Ganoswasthya has 43 primary health centers. Each center has to do at least 3 to 4 satellite courtyard meetings in the villages. So that means in a year, we have had about nearly 2,000 satellite courtyard meetings in the villages. They do the campaign, they do aware, they do collect the patients and register the patients for NCD and other diseases. Those who are not manageable at the primary centers, they are referred to the secondary centers where the lab, indoor and counseling and referral to tertiary hospitals if required. In the tertiary hospitals, we have got 2 centers where all the specialists are there, including advanced lab. And most important thing is that in all these centers, Ganoswasthya provides the medicines and lab at a minimum cost, which is nearly 1/3 about the cost of the other pharmaceuticals, because Ganoswasthya has its own pharmaceuticals. Not only that, Ganoswasthya also has a refugee health service in the refugee camps that the 11 lakh refugees has come from Myanmar. We have got in a 33 camps, we have got 9 health centers and then 2 hospitals. And our target population is 3 lakh. You'll be happy to know that in the last year, total 6,566 diabetic patients has been identified. Total 12,620 patients of hypertension has been identified. And of course, the cerebrovascular accident and cardiovascular incidents were quite low. Here, I am proud to show you some of the NCD programs of our nation. Nationwide, Bangladesh has got 13,000 community clinics. They are the peripheral units of the government. They maintain registers. They have good medicines and equipments to serve the villages in their catchment areas. They entry the non-communicable diseases in their non-communicable center, and they are finally referred to the sub-district hospitals or Upazila hospitals, where there is NCD corner, there is a digital corner for registration, there's trained doctors, lab supports, and free medications there. You'll be happy to know that all the government hospitals have got all the medicines free of cost. The antihypertensives, the diabetic drugs, and the anti-cholesterol lowering drugs, they are free of cost. And once the patients are registered, they are given free medicine for 1 month. They do maintain the register, and if the patients are lost follow-up, they contact them for follow-up. Here are the booklets the government has provided for the management of the diabetic patients in the community clinic areas, the management for diabetic and hypertension. So ladies and gentlemen, now I am coming to the point, what are the challenges that we face in Bangladesh as a nephrologist? The most important thing is the lack of awareness, the challenges to diagnose chronic kidney disease. There's the most difficult problem was referral to the higher centers, difficulties in follow-up, and the management of kidneys is a very costly affair. And finally, we couldn't convince the authority regarding the gravity of the disease. Regarding the lack of awareness at all levels. The patients who are suffering from non-communicable disease or kidney disease, they are not aware that they are having a grievous disease. Their relations, their caregivers are not aware. The society and the primary health care are also not aware that this disease is going to harm a lot. The diagnosis of CKD is difficult because they need trained staff to take history examination, needs lab support. And in many situations, after the primary investigation, the cause of CKD remains undetected and the exact management is not easy. And many a time, the advanced lab investigations are not available in the district and sub-district levels. So as such, there will be delay in referral from the family level, patient level, and primary healthcare level that prolongs the disease. And patients face a lot of difficulties to come to the specialist. You will be surprised to know that we have got about 300 nephrologists for 170 million. That is about 1:5.66 thousand population per nephrologist. And the cost of transport and difficulty in transporting is also very difficult. And the costly business of CKD management, patient has to go to the hospital or doctor. They have to pay. They have to pay for consultations. They'll come to investigation, medicine, diet, and renal respiration if required. So all these things is that we can convince our authority, we can convince the policymakers that CKD is important. CKD needs to be included in the WHO policies to be a non-communicable disease. And if we could make it, the management of CKD would be much easier. So thanks to everybody. I am thankful to the Non-Communicable Disease Control Department of Bangladesh government and to my seniors, Professor Manjur Kadir, Dr. Rezaul Haq, and Shahidul Islam. Thank you very much. Goodbye. Welcome to Bangladesh.
Thank you, Professor. We hope that we can come visit you in person someday. But also thank you for explaining some of the challenges. And I think some of what you've said links to how we opened in terms of Bali's reflections on the difficulties of providing services to people in conflict situations or people that are displaced, and particularly when such technical services are required, such as dialysis and so forth. So
thank you very much. Thank you very much.
Thank you. So I am going to open the floor. There's a question by Anne-Louise in the chat, and another question by Estela also in the chat. So I will propose, since we have 19 minutes, that speakers can answer the questions in the chat by typing. And then I can see that there are hands up, Mansoor and Samia. So let me take those questions also, and then we can do a round of questions, and the panelists can take maybe 2 minutes each to respond. So Mansoor, Samia, and then Claudio, please. Mansoor, are you there? Okay, if not, then maybe Samia, would you like to go? Okay. Samia's microphone is not opening. Maybe Claudio, unless the settings prevent them from speaking, I'm not sure.
I'll just try. Okay.
Okay, great, thank you. So I see it's a problem with the microphones. So
I'll just whom should I unmute? Lauren?
Mansoor, Kadir Ahmed, Samia Afrin, and Claudio Shuftan. Their hands are up, so you should be able to spot them. Thanks, Claudio, for flagging that the microphones are blocked. And I can see Sundar is typing an answer to Anne Louise's question.
Just a second.
Thanks, Deepika.
Okay. Okay, I can see Samia first. I'll yeah, Samia, you can you can go now.
First of all, I say congratulations all of panelists. This is very learning
Samia ji,
session.
you should be able to speak.
Can you hear me?
We hear you, Samia. Please continue.
Yes. This is a learning session, I think, and lots of issue arise, and we learn lots of things, and we can arrange again and again this type of webinar for further learning other people, and mainly learn for PHM country level members also. And also, it is so we heard all of discussion, and I want to only congratulations all of our comrades and our friends. Only this one. Thank you very much.
Thank you, Samia. Manzoor.
No, I do not have really a question. Maybe accidentally I pressed the button hand raise. Thank you. Continue, please.
Okay, no problem. Thank you. Then I'm going to hand over to Claudio.
Thank you very much. I just want to highlight the resilience of the corporations. I would pose that our increased denunciation of the commercial determinants is probably one of the explanations why we have seen such growing corporate capture of United Nations agencies. So when we attack, they counterattack. And that is absolutely clear if we look, for instance, of an example that is over 20 years, and that's the voluntary guidelines that were pointed out by our colleague in Argentina on the breastfeeding substitutes. The fight has been tremendously onerous on several organizations that have devoted full time to try to keep the way the corporations that produce these substitutes wiggle to get away, saying that they are complying with voluntary guidelines. Voluntary guidelines don't work with corporations, period. If you look, for example, another point that we heard from our colleague in Argentina of ultra-processed foods, the resilience of the corporations is again demonstrated by the fact that we denounce too much sugar, too much salt, and trans fat in the products that are sold to us at cheap price. So what is their response? They reformulate, and then they greenwash their consciences by saying, oh, we have the same product, and now they put it in the label, less sugar, less salt, and no trans fats. But we are still hooked on junk food that may be a little less bad for your non-communicable diseases, but it still has the components that are part of the problem. So we have to be clear that we are fighting against enemies that have a very thick skin, and we need to have strategies that hit frontally. The labeling is one of them, the taxing is another one of them, but probably the naming and shaming is supposed to be another one. I don't see in the presentation of WHO that these points have been highlighted. So dialoguing with corporations, we know it doesn't work. So we have to act. Act means hitting them below the belt. Thank you.
Thank you, Claudio. So maybe before I hand over to Danny, because I can see his hand is up. Monika, do you want to come in and maybe say a little bit about how your unit is thinking about binding versus voluntary regulations, and also if you're following the treaty process, the process on a binding treaty on TNCs, and thinking about how that intersects with your work? And then maybe, Danny, could I ask you to mute until Monika's finished commenting, because we're getting some sound from your microphone. Thanks.
Thank you very much, Lauren, and thank you, colleagues, for the question, which is a very important one, and certainly one that is, it isn't something that we're not aware of. So I can assure you of that. So if I answer the second part first, we are aware of the treaty. The next intergovernmental working group, as many of you will know, probably is on the 24th to the 28th of October this year. The documentation for that is already available, that has been put up by the UN Secretariat, including the different member state and civil society positions that have been put forward on that. So it is an area that we're following closely, and we are aware of the way that has conceptualized or included health in its current form. The second question that you asked about the effectiveness of difference of regulation versus self-regulations on this, of course, this is something we're very aware of as well. The evidence base is not insubstantial on it. I think it's we have a theory of change under development, and one of the points that I didn't mention because we didn't have enough time to go into the detail of what we're undertaking as a technical development. But one point that for me was very important, and we discussed with the experts through the expert consultations, is a clear theory of change on commercial determinants. So having a very a good articulation of what it is that we expect as an outcome, what are the assumptions that we have going into that, what are the limitations of that. And as part of that theory of change, which looks at the different avenues and different drivers on commercial determinants, this plays a very pertinent role. I hope that we can publish the draft 0 for that later this year for further consultation and input. And when the scoping paper for the global report is also published, so that we're taking our time on this area of work. It's a complex area covering different public health policy areas, the risk factors, and the many permeations within it. It is a very big cake, and we've taken our time to see how the best and most effective entry point is now for us to start the formal process of WHO work in this area. And for the global reports, we undertook a desk-based review over the first 12 months of functioning of the unit, and now we're in the development of the scoping paper, which I hope that we will have published either towards the end of this year or early next year. And there will be a public consultation on that scoping paper, and I very much hope that that you are able to contribute to that and to give us your feedback, and of course you know how these processes work very well, so that it's incredibly important that we have those perspectives, particularly where you think that we need to strengthen some areas versus where perhaps less attention on other areas. And perhaps a comment in relation to this, if I may, Lauren, before we pass to Danny. Many of you know the WHA processes very well, so of course we have to maintain a separation between the normative work and the development of different products and tools. And in the expert consultation, the literature review, the literature in this area is very broad in one way, but less broad in others. And one of the main gaps that we identified in that is the importance that civil society plays, and how that manifests itself, and how that is either supported through member state processes, through member states, for example, financing, through public financing, through different avenues for organisation, and how important it is for civil society to be engaged in this area of work in order to hold us to account, but also to hold others to account, and to bring the community perspectives into it. And I noticed one of the comments in the chat was around community institutions. It's also something that we're particularly aware of on the commercial determinant side as an area that we need to pay greater attention to. So thank you for that question, and it's something that we are very carefully including in the work so far.
Thanks, Monika. So I'm going to hand over to Danny, and then Dr. Vinod Shah, your hand is also up. Please follow after Danny with your question. Thanks.
Thank you so much, Lauren. I'm Danny Goethe from Uganda. I really wanted to ask about, I've not had any sharing around the cost of diagnostics and therapeutics, and I'm speaking specifically on type 1 diabetes, which is really taking so many of our people just because insulin is very expensive. Are there any global mechanisms that have been put in place to advocate around lowering of the costs? If they are, how far have they gone? Relatedly to what we've seen in, access to these technologies so that we have local production in Africa, for instance. Is there any effort to that? Because importing these therapeutics and diagnostics from Europe or wherever is very expensive for us. So I don't know whether anybody has done any advocacy around that, or a position of PHM in that regard, in regards to costs of diagnostics and therapeutics for NCDs.
Thanks, Danny. So Vinod?
Quickly respond to Danny. I just want to say there's a number of moves, surprisingly, just on this front. And there is something called a Global Diabetes Compact, which has been forged between pharma, multi-stakeholder representatives to talk about. But we have richly criticized it in our draft, simply because they have limited it to dialogue. And our comment calls it a supplicant strategy, where you are sort of saying, please, can you do that? You're just a sort of appeal to being nice to come through it. And after a number of meetings, they have not even made any concrete offers on that. But yes, they are seized. Everyone is seized at one level of the issue, that without breaking the bottleneck on insulin, the entire system of insulin, we are not going to go anywhere on this. But there is this global, there are 2 or 3 reports on this, and there is this central strategy that we need to really enter into, engage with.
Okay, so Vinod, and then also just to flag, out of respect for the interpreters, we really can't go over the time much, maximum, I would say 2 to 3 minutes. So Vinod, and then I would ask the panelists to have quick 30-second closing comments, please.
Yeah, thank you very much. It's really a very nice session. We also learned a lot from that. I just wanted to give some information related to India, because in India, nearly 5.8 million, they die from non-communicable diseases. And so one in 4 Indians has a risk of dying from non-communicable disease. And it's being a vast country and vast population, it's a great challenge for India to get control on these non-communicable diseases. India is trying very hard, ministry is trying hard, but WHO is working, all medical industries, they are also helping us a lot in producing awareness program. But still, we saw that we cannot reach up to the rural India, and most of our people, they stay in rural areas. So we have to have some guidance how to go to the rurals and then give them treatment, because they don't take any treatment also for months together unless they become serious and come to the primary health centers. Actually, Public Health Foundation of India and this Healthy India Alliance, along with NGOs like our Janaseva Foundation and other NGOs and some civil society organizations, we are having networking all over and even in various states, and we arrange our programs and we involve various people living with these non-communicable diseases, experts, academicians, and we try to produce this awareness and all. But then still India is lacking a lot. So anybody interested in suggesting some programs will be very happy. Thank you.
Thank you, Vinod. So I think because we're almost at the edge of our time, I would like the panelists to share final thoughts very succinctly on some of the suggestions they have, especially for country level and regional advocacy on these issues, and I'll summarize some of those in the chat. So let's start with Billy, and we'll just go in the order in which people spoke. Thank you.
Ok, merci beaucoup. Je remercie en fait tous les panélistes. Ça a été très intéressant cette session et nous avons bien partagé les expériences. Maintenant, là, nous comprenons qu'il y a des défis à relever et au niveau international, donc c'est-à-dire dans la globalité du mouvement, mais aussi au niveau spécifique des pays. Parce que là, je vois, comme en Afrique, par exemple, les MST aussi sont à la base de plusieurs morts, comme a dit le deuxième intervenant. Plus de 70% des morts sont dus aux MST. Et l'Afrique a une grande population aussi, comme l'Inde. Donc, ce sont des questions importantes qu'il faut pousser des réflexions et voir comment aider, comment faire des plaidoyers au niveau national, donc au niveau des pays, mais aussi comment orienter et plaidoyer au niveau mondial, au niveau de l'OMS, au niveau mondial, pour que certains aspects de MST soient pris en compte dans le soin primaire. Ça va aider que nous allons finalement commencer à trouver des solutions à ces défis. Merci beaucoup.
Thank you, Billy. So next we have Monika.
Thank you very much, and thank you very much to the People's Health Movement for inviting me to be able to participate and also to listen to you and to hear the different contributions from my fellow panelists, but also the questions and the comments from the floor. I think this is an incredibly important issue that we cannot afford not to work together on, and so I'm particularly grateful that we can do so, and we can continue to engage in this as these discussions mature at the WHO level, and it's a big beast. Particularly, I think you will agree that this is not a straightforward task at all. However, there are the call for evidence in this area, which is one of my priorities for the coming period of time. It needs to go beyond the traditional literature evidence and that we are more used to working with, and the call for evidence, particularly at the community level, some of the realities of how the commercial determinants manifest themselves on the ground is particularly important. And we know that they manifest themselves along the lines of inequality and harming those that can afford it the least. As we move forward, I would be very grateful to continue to speak and to listen and to learn and to to engage with you also on areas that we touched on less, where the commercial disseminants are very prevalent. We know that the impact, for example, on habitats and pathogens relating to malaria and vector-borne diseases are very closely linked to industrial practices and deforestation and so on. And there are synergies across other areas that go a little bit wider than some of our traditional focus on commercial disseminants and in the risk practice. So I do hope that this is the first of a continued conversation, and I very much look forward to continuing this.
Thanks, Monika. Anton.
Yeah, maybe like to stress the point that this multi-transnational kind of like corporate power has to be counterbalanced, in my view, through this transnational kind of civil society action. Because just as an example, what Andrea said is really helpful in the German context, where we're establishing front of package labeling, but it is a catastrophe in the way it's being executed and pushed. So we can have like a frozen pizza or Kellogg's with an A rating, which is the highest, because it's just really being done in quite weird ways. So I think like connecting experiences, learning from that, and then having a lot of evidence also, as Monika said, to go forward and to counterbalance these narratives.
Thank you, Anton. Sundar?
Yeah. I just wanted to appeal that this sort of policy analysis at the regional conference level also, there are a number of documents that come forth which are very important. I just saw the Southeast Asia on the WHO tracker. We have put up our comments on that. I hope more people from the PHM get into policy analysis and help their country circles and their regional circles with contributing to it. And that, I think, is an important role that we need to play. There is, other than the policy analysis, we need to reach out more to our LMIC representatives from our countries who go to Geneva, who are rather clueless sometimes about the implications of what they are signing on to, or even what they should be asking. So many of them are willing to ask, but at some point they have no source to be briefed. I think we need to build up, help them, and that I think that's the thing. And finally, I think somewhere we need to make them accountable. They go to Geneva and they sign off these declarations and they come. So we should use the WHO declaration to demand action from our country with all its weaknesses, even if it's not a binding commitment. That sort of action at the country circle should really be happening more regularly. Thank you.
Thank you. Andrea.
Bueno, agradecer y celebrar este tipo de encuentros, porque precisamente en estos espacios es donde podemos no solamente tomar conocimiento de políticas en las que algunos países avanzan, sino también poder aprender de sus logros, de sus aciertos y de sus errores. Y eso ha sido crucial en la región de las Américas. Y también, digamos, poder problematizar algunos aspectos como los conflictos de interés y la necesidad de poder fortalecernos como sociedad civil para tener voces libres de conflicto de interés y poder tomar evidencia libre de conflictos de interés. Creo que es un enorme desafío en el que hemos podido avanzar a nivel regional y que es súper rico y valioso poder encontrarnos con otras regiones para también poder ir aprendiendo de aciertos y errores. Eso, gracias.
Thank you, Andrea. And then Professor Mustafi, you have the final word.
Yes, thank you very much. I learned a lot from all the August presentators. And I do not know how far I could convince that the NCD control program in our country is, I think, is going quite smoothly through government level and non-government level. There are good platform and there are good structures has been developed. And I am not sure that how far the WHO authorities has been convinced with my presentation that CKD is very important and should be included in the list of the non-communicable disease chapter. So thank you very much, all my friends and colleagues. See you again, inshallah, sometimes in future. Goodbye.
Thank you, Professor, and thank you, everyone, especially the interpreters who have stuck with us for 8 minutes extra. I'm wishing you a good weekend and looking forward to seeing you at the Health Systems Thematic Meeting, which is the first Tuesday of every month. So take care, and the video will be up, I'm sure, and
Goodbye.
20 minutes available. Bye-bye.
Au revoir.